our webinar series, Canadian Human Factors in Healthcare. Today, our call is Communication During Transitions of Care. Is there room for improvement? Our speakers will talk for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box or the chat box, and they will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, similarly, please connect with us in the chat or question and answer box, and we would be happy to assist. Finally, please join us next month, March 21st at noon Eastern Time, for the next webinar in our series as we present International Approaches to Health Information Technology Safety. With that out of the way, CPSI is pleased to present our two speakers for today's presentation, Drs. Irene McGee and Jordan Anderson. Dr. McGee is an Associate Professor, Anesthesiology, Sunnybrook Health Sciences Center, University of Toronto, Engagement Facilitator for improving patient-provider communication and interprofessional collaboration with the iStartEnd tool, and more. Dr. Anderson completed her anesthesiology training at the University of Ottawa, Northern Ontario stream of residency. She completed a fellowship in cardiothoracic anesthesia and critical care medicine at Duke University and a master's in public health at the Harvard School of Public Health. Her primary area of research interest is the application of human factors to improve the safety of handover of care with an emphasis on distributed cognition and the impact of technology. She was the physician lead of a multidisciplinary group to develop and launch an electronic handover of care tool at the Ottawa Hospital. Over to you, Irene and Jordan.
Thank you, Gina, and welcome everyone. I'm going to start by telling you what happened to me last week. A young woman had a procedure to revise a brain shunt. As the anesthesiologist, I saw her in recovery. I was concerned because she was quite drowsy and not moving her right leg well. The surgeon felt perhaps a CT scan should be done right away. We spoke to her family. They told us that she had had a significant right leg injury just a few months ago and was still doing physio to regain its strength. No scan was necessary. She was discharged the next day without complication. What would have happened if the family had not been there? Today we are charged with the following objectives. Number one, to understand the complexity of challenges we face when sharing care across teams and places. Number two, be familiar with iStartEnd, a tool that facilitates engagement and effective communication in various settings. And three, last but certainly not least, what we said is not what they heard. Appreciate the human factors that make this true and how to manage this reality. I'm all about engagement, so I'd like to introduce another member to this webinar. So who knows who this is? The hint is that the initials are MW. Write it in your chat boxes. A very quiet audience. In any case, let me tell you, this is Marcus Welby. He was a TV role model for family doctors, and he was at your side from cradle to grave. He knew all about you. He knew your story inside out and only occasionally had to reach out to others for advice by phone. That was then, and this is now. The new paradigm in medicine is complexity, things changing over time in an unpredictable way. The care we can now offer patients is amazing, but so specialized that not any one care provider can do it all. This has led to the concept of shared care across teams and the need for reliable transitions of care. Here is the scope of the challenge, as described by the Institute of Medicine in a report from 2012. Did you know that every year the average elderly patient sees 7 physicians across 4 different practices? And physicians in private practice will interact with as many as 229 other physicians at different practices each year. And the average surgery patient is seen by 27 different healthcare providers while in the hospital. Through all this complexity, the only constant is the patient. Ask, listen, talk is an essential practice because you can't give what you don't have, as in my example. In the link attached to this webinar, there was an example of a primary care provider quarterbacking his patient's care. Over 80 days, it involved interactions with 9 clinicians 40 times by email and phone, other healthcare team members on 5 different occasions, and meetings with the patient and spouse on 12 occasions. You can imagine the challenge, this being just one patient in a busy primary care practice. So this is what it boils down to. I wonder if anybody would like to guess what this image is about. I'll give you a hint, and the cell phone screen is broken. Okie dokie. This is a hot potato meeting a broken telephone. And essentially the metaphor is that the patient is a hot potato and the broken telephone is what happens with transitions of care. There is definitely room for improvement. We often parse a patient's care out to so many experts that context is lost, and so an understanding that is key to a patient's care is also lost. Healthcare today, beyond primary care, is delivered as episodic care encounters, or in parts. Aristotle had it right when he said the whole is greater than the sum of the parts. Robust transitions of care are necessary so we can understand the whole and can help better navigate this complexity both for patients and their providers. Because this is what we get. We get splat. We have stranded patients looking after themselves. I think we can do better. 9.5% of all deaths result from unwanted variations which are endemic in healthcare. So developing consensus protocols that streamline the delivery of medicine and reduce variability can improve quality and lower costs in healthcare. Variations are actually implicit in care transitions because they occur among providers who often don't know each other across various care settings and involve patients with complex stories that are continuously changing, and they can be difficult to keep straight. We'll be talking about I-START-N, which is one such consensus protocol. This image is called the hierarchy of effectiveness. It sets out the various ways we can improve transitions of care and other quality improvement initiatives. Today, we're at the bottom level, the education stage. It is a person-oriented strategy, and others are rules and policies, reminders, checklists, and double checks. The point is that these are person-oriented, and human beings are fallible. So system-oriented strategies are often better because they are more effective and easier to impose. And so we're going to look at simplification and standardization as it fits into a consensus protocol. So, oops, here we go. So no point reinventing the wheel. There's lots of high reliability organizations that have been facing these challenges for quite some time, such as the nuclear power industry and aviation. Their transitions of responsibility are hardwired into their systems. These transitions are processes that happen every time, and they happen in the same way every time. Some of the features of these transitions are that the communication is always person to person. They minimize all distractions. They use a structured framework and then document the data. And as well, they discuss what might happen next and the plan for next. And there's a readback at the end, which we'll also be addressing. I-START-N is an acronym created to facilitate engagement and effective communication in various care settings. When a transition of care is occurring, Introductions are key. Who are you handing over to? Check the patient's ID band is on and correct, and it's vital that the patient and family know who is taking over and in what capacity. S is for story. The patient's story must be central, correct, and complete at every transition. I know some places hand over in the presence of the patient and family to ensure that there is actually clear, shared understanding every time. Review the treatment plan with the receiving team. Who will do what and when, so care will be seamless across the transition. Discuss adjustments or any other additional considerations depending on the patient's wishes or comorbidities, and engage the patient throughout care transitions as they may change their mind. And what else do we need? Complex care often requires many resources, special monitors, drugs, equipment, other help involving the patient care provider. Being proactive and organizing this will enable timely care, including making plans for what the patient may need at discharge. Timely updates. Probably most important is recognizing that the patient's condition is dynamic and evolving. The receiving team should meet the patient and check the patient's status, vital signs, before the center leaves. This improves transparency and accountability and will minimize care disruption going forward. And before exiting, just discuss what you think might happen next and the contingency plan for next. Leave your name and contact number and document the care you provided. Every care transition can actually be an opportunity for improvement. Ask if there are any questions and get a readback. This is a good time for a debrief as well. What went well? What could be improved next time? So how does the cognitive aid iStartN work to improve transitions of care? Number one, it creates standardization. When the same language is used, shared mental maps are developed, which will help with understanding and retaining the information. The tool also creates expectation and opportunity for the team to speak up. It hardwires iterative processes around healthcare information, care management plans, and relationship accountabilities are openly and actively reviewed in a continuous way. This tool is very versatile and can be used in various forums, and this will be available to you online, but this is the different ways that the tool can be applied in different settings. The healthcare team, during handover, and I was trying to make the tool something that perhaps patients could use when they're trying to navigate a new encounter with a healthcare provider. More about this in a moment. No discussion about transitions of care would be complete without discussing SBAR and IPASS. SBAR is really useful when needing help around a particular event, example, making a call about a patient that's had a fall. And IPASS is used on wards where care is shared among a team of house staff. Care plans are summarized with this tool, and then when responsibility is taken over by another member. This is the iStartN cognitive aid. It was initially created to enable ad hoc or transitory teams to gel in the moment and move beyond just individual competence to collective competence, a term coined by Lorelei Lingard. The tool is unique. The red asterisks show where space is created for the receiver to jump in, be engaged, and speak up. This brings us to objective 3. Why what I said was not what you heard. The center is 100% responsible for ensuring that information is sent successfully. Is this true or false? Given I haven't had a lot of response during this webinar, I'm going to give you the answer, and the answer that this is 100% true. And in a way, it's a good thing, because just think, it really empowers you to know that it is up to you to make sure that information is transmitted successfully. So who is receiving? It is important for you to focus on your target before you execute the throw. What we're talking about here is setting up your receiver for success. So how do you do that? First, you should know your receiver. Are they there? Is this just a nurse that's filling in on break, or is this the nurse who will be looking after the patient? Ditto for the physicians and other healthcare providers. So know your receivers and make sure they're present. And are they ready? Is this the right time or place to be sharing important information? You should minimize all interruptions and distractions. We talked about standardizing the format and making sure that critical handover information is shared and documented, and as well that the sender will leave their contact details, and always ensure that the patient and family are partners in their care planning. Okay, since this is a lunchtime session, for some of us anyways, this was the last skill testing question. What are you asked at the end of placing a pizza order on the phone? It's a read back. If you notice, every time you've placed your order for a pizza, they will read back to you exactly what you're going to get and what kind of pop you would like with it. So just, it's a really important concept that just because you sent a message doesn't mean it was received and understood the way that you thought it would be. Just trying to advance the slide. So at the end of all this, I wanted to end on a positive note and talk about that SLAT could actually be smart patients looking after themselves. And to that end, I spoke with Donna Davis with the Patients for Patient Safety, and I asked her about how iStartN might help patients be co-drivers in their care. She suggested a questionnaire that a patient files before each visit. So I kind of developed a questionnaire that takes in the iStartN elements, and here it is. And at this point in time, I would like to pass on to Jordan, and she's going to tell us her experience with transitions of care and how electronic medical devices can really help us do this well. So right back to you, Jordan.
Thanks very much, Irene. So I'd like to expand on what Irene's been talking about. So you've heard a lot about the importance of handover of care, all of the team members involved, and how complex it can be, particularly as the patient's needs become more complicated, as more and more healthcare providers become involved in their care. It can often be very difficult to keep track of all of the information and to make sure that the whole team has that information. So increasingly, we have all sorts of tools that are at our disposal in a medical practice, in a hospital, for all the different healthcare providers, and more pieces of information technology, both computers and computer systems, as well as portable devices, smartphones, iPads, and those sorts of tools are being used in the healthcare system. So Irene was talking about a lot of the different methods that we have to create change. So we can teach everyone how to give better handovers. We can implement system-wide tools. We can have checklists. And just as one more of these pieces that all together layer up to create safer handovers, we started to use more and more information technology to help with that as well. I'm going to show you, before I start, just a quick disclosure. All of the funding for the work that my team did developing the e-handover tool, as well as the research that we're doing in handovers of care, all of the funding was provided by innovation funds, the Ottawa Hospital and its department, and the university. I don't have any commercial stake in any sort of IT shenanigans, so just to mention that before I proceed. All right, so I'm going to show you a very simple process map here that we developed very early on. So the project that we were working on at the Ottawa Hospital was to launch a physician-wide handover tool that has since expanded in recent years to studying handover for all of the different specialties in the hospital, so from our paramedics through to our nurses, our occupational therapists, physical therapists, our physicians as well, and then the most important part of the team at the center of it is the patients and their families. But for the sake of having a graph or a process map that will actually fit on a PowerPoint slide, I'm going to show you right from the start where we were starting to study things just in our own little PACU, which is the recovery room. So just for a simple little piece of information to travel from, say, the resident on call one day that a patient needs morning blood work for the next day, to get on to the person the next day who's in charge of checking that result. There's a whole lot of places where information can or should be passed. Now, there's some positive and negative drawbacks to this. So perhaps one of the people in that sort of chain isn't aware of the information. Often if there's a team, then other folks may be aware and might be able to fill in the gaps. But this still requires a whole lot of different pieces of communication to happen between different folks. And again, this is just the recovery room, which is a pretty small and pretty simple area of the hospital. Patients are in there for a short time. There's a limited number of healthcare providers involved. And even so, it gets a little bit complicated. So what we aim to do is to create some sort of central handover tool, or in our case, a handover iPad app that would help to keep track of all that information. And in doing that, none of this is ever meant to replace all of those wonderful things that Irene was talking about. So having a face-to-face handover with communication, with a checklist, so you make sure you go through all of the pertinent information, and also with the opportunity for readback to confirm that what you think you said is what was actually heard and understood. But the idea here was to create one more layer, one more sort of layer to that safety net to make sure information isn't getting lost by also having an electronic tool as well. So a central handover app where each patient's current issues, their needs, any to-do lists for them would all be checked and updated in one place to make sure that everyone has the same. And again, because this is recovery room and because this is early on, you don't see as much in terms of all of the nursing staff and all of the other allied health, again, just for the sake of simplicity and fitting on one PowerPoint slide. But once you add in all the layers, it starts to get pretty tangled. So what does that actually look like? What are our goals? So we want to make handover safer. We want to make sure that those key pieces of information are lost or misunderstood. We want to make sure that information is shared between all of the team members. So that may be just a couple of folks, that may be one on-call person handing over to the next on-call person, or it might be a whole bunch of different healthcare providers all looking after the same patient. So you might have, in Irene's example, there might be over 100 different professionals looking after one patient. So we want to make sure that information is shared and that everyone is on the same page. We were talking a little bit earlier about mental mapping and mental models. Basically, we want to make sure that everyone is looking at the same patient. So in terms of everyone is seeing the same patient in the same way, that everyone understands what's going on, what the issues are, and has the same picture of what's important for that patient, what are our goals, what are the needs, and what are the to-dos. And there's another layer that always comes in anytime you're developing an electronic tool, and that's to make sure that data stays secure. This was an issue back in the days of paper charts as well. Charts could get lost or misplaced. Charts could be left out where they could be read by the wrong person. But that gets expanded exponentially when we're talking about having an electronic tool. So we want to make sure in doing any of this that we proceed very carefully, that both patients have access to their information and that no one that shouldn't have access to the information. So in terms of what that looks like, this is obviously not real patients, but this is an example of what we developed several years ago. And at the time, this was about 5 or 6 years ago, all of the physicians at the Ottawa Hospital had iPads that they could use to do things like check patients' blood work, look up x-rays, look up old notes and clinical files. But it was primarily being used at that time as a passive tool to access information. And so what we did with the help of the IT team was to develop an active tool layered onto the clinical mobile roster. So you have your list of patients on your service, and then you can do things like check their blood work still, but you can also keep track of things like their problem list. You can write notes or read what notes other people have put as far as specifically handover. So this isn't a comprehensive chart, just the big issues, and then the tasks to do. So what needs to be done? And this would be accessed by all members of the team looking after the patients. When we developed it, we had to start somewhere, so we started with just the physicians, but we've been in the process of studying and expanding and looking to make it a tool that's useful for all sorts of healthcare providers, not just the physicians. And a couple of things to point out, again, just building on all of those principles that you've been hearing about already, but things like knowing who are your sickest patients is very important. Who are the ones to watch overnight? Who am I most worried about, need to keep a special eye on? So the system will automatically put those up to the top so that you don't miss them, so that they're not buried. You know, if you had a list of 30 or 40 patients, it would be much easier to miss those at the bottom of your list. You know, knowing what their problems are. The one common issue when people hand over, particularly if you're on a service like, say, internal medicine or geriatrics, where you've got many, many, many patients you're looking after, is you spend a lot of your time as the receiver, as the one getting the handover, writing down a lot of notes, trying to keep track of, okay, this patient needs this blood work checked and that patient needs that done, and who was it that had this disease again, and trying to just write everything down as your brain is processing it. So one of the other things that this tool was designed to do is take that cognitive load of just scribbling everything down away from the receiver so that they have more time to process what needs to be done, and then analyze the information, synthesize, and then read back. So that was the idea. Our geriatric service, when they started using this, found that their list of patients took about 20 minutes less to hand over than it did before they started using the electronic tool. Again, primarily because people weren't busy scribbling things down and they had more time to focus on the actual patient needs. The other nice thing about this is that it's accessible by all members of the team, and then again, the tasks can be either added when someone adds something that needs to be done, and also taken away. So a different person might create the task to do, then actually remove the task at the end. All right, and last but not least, it's not just us grassroots doing building handover tools at our hospital level, but there will certainly be many companies. I suppose the most well-known of those is going to be Apple. They've got a health records app already in beta testing now that you'll probably see roll out during this calendar year. And the idea with this and many other tools like it is that more and more health records aren't just living in a medical records room at a hospital, they're living with the patient. And often those patients that Irene was talking about, the flats, the really enthusiastic, organized patients will come in, say, to an office appointment, and they'll have a list of their medications, and they'll have a list of their surgeries, and all of their pertinent medical history, which is absolutely wonderful, because sometimes finding that information in the hospital records can be quite challenging if you don't have a system that puts it all together, and you're trying to piece it together from a paper chart. So that's absolutely wonderful, and more tools are being developed to make that easier, both for patients and for healthcare providers, to get the big picture. So again, it's another example of using an electronic tool to create one mental model of what's going on with that patient, one reliable source of information of what medications are you taking, what's the up-to-date list, what is your up-to-date allergy, and all of those things. And again, bringing the people that are really at the center of all of the care, the patients and their families, and putting them right at the center and having a health record that they can access as well as their healthcare team. So that will be coming soon to an iPhone near you, and more tools, this one and others like it, we hope will help to layer on all of those things that we're already doing in terms of handover checklist, handover safety, making sure all of the information is understood by all of the increasingly complex members of the healthcare team. Thanks very much, and I will pass the ball back for questions and anything further.
Thank you both so much for your great presentation. We've received a few questions from the chat box, which I'll read now. Irene, where did you implement I Pass the Baton, and how did you ensure that there was uptake from the staff and the care team?
Okay, thanks for that question. I believe you're asking about I Pass the Baton. I'm familiar with that tool, but it's not a tool that I've actually used. With regards to the tool that I described, I Start End, we've used it for patients going from the cardiac operating room to the cardiac ICU, and we actually did a study to show that it did improve care and didn't add time. And so that is the best I can do to answer that question.
Thanks, Irene. I guess your tool was called I Pass, correct?
No, that just comes back to communication, doesn't it? No, the tool is called I Start End, and we went through what all those letters stand for. And it's out. There are many tools out there, but I really like that tool probably because I created it, so it meets my needs. But I've also seen that the residents tell me it's very versatile and can be used in many settings, and that was what I was trying to show. I did mention SBAR, and I did mention IPass, and that was just to let you know that there are lots of tools out there which addresses the fact that simplification and standardization of transitions of care, whatever you're going to use, is a really good idea.
Great. Thanks for the clarification.
Okay, you're welcome.
Irene, in addition, teach-back isn't often helpful with patients with addiction issues. Any suggestions for this particular group?
I think basically one of the things I think we can flip it around, which is I think that very much we want the patient to be the driver, whether they're addicted or not, because that's where you have to start, is where they're at. And I would say that you would start out by having a questionnaire that covered what the patient's current issues were and how they viewed their situation. And then the patient would come and see you, and I think the starting point would be framing what the expectation should be for the interview that you're going to have. Teach back, I think in a way it's almost you can flip it on these people and say, now that you've given me all the information, I have all this information about you from your questionnaire, and it could be an electronic version, you actually read back to the patient what you know about them and how you view their situation. Because you're right, they might just get really annoyed and shut down, as opposed to you're kind of inviting them and saying, okay, thanks very much for that, and this is what I know about you already, so let's see where we can go from here, and then try to start a more open conversation in that way.
Thank you. This question's for Jordan. Jordan, we all know how technology, when used appropriately, can, oops, sorry, I just need to scroll down a little bit, can positively impact patient safety. How did you work to customize your technology to suit your needs?
So that's great. I was very fortunate, well, for a number of things. One was that the Ottawa Hospital at that time was using, we already had the tools in the hands of all the care providers, so iPads were already widely disseminated. That helped a lot. The clinical mobile platform that we were using incorporated elements from a lot of different tools, but was actually an in-house build that, again, incorporated pieces of different bits of software. So we had folks that were able to customize for our needs. And then we started with a very grassroots approach. So we approached people from all of the different departments in the hospital to send representatives to be part of our development team. And we had a really wonderful IT development team who was very keen to work with the healthcare providers, and then a big group of healthcare providers who were all interested in IT and very excited to work with them. So at the very start, we started by doing a current state analysis to see what were all of the different ways that handover was being done in the hospital. And may not be a terribly big surprise, but everyone sort of had their own ways of doing things. And part of that is a lack of standardization, and that can certainly be improved upon by tools like Irene described. But part of it is also that different areas of the hospital have very different needs. The handover that you're giving on an emergency department patient that's only been in the hospital an hour is going to be very different than handing over a full geriatric service of 40 patients who are very complex and may be in the hospital for months at a time. So there's a certain amount of standardization that is good, but we needed to build in flexibility so that people with different needs could use the tool in different ways. So lots of input from day one from both the healthcare providers as to what they needed and the IT professionals as to what was possible. And then we launched using an iterative design process. And again, let me know if I'm getting too off on an IT nerd tangent, but basically what that means is we roll out a version of the tool to people that are very interested to use it early on. We get their feedback, and as we implement each subsequent rollout, we make changes to the tool as we get feedback from people that we're using. So again, different folks wanted to use it in different ways, different people wanted different functionalities. So there are actually many different versions of the tool before the one that we're currently using now. And that was just sort of, you never really know what you're going to get until you use it in the actual real world. So we were making changes as we went to tailor it to the users.
Great, thanks. You answered the second part in the chat box was the clinician input. But further to that question, for the development of this type of app, did you involve patients in the development?
Absolutely. So we did get some information early on. The next phase of our research that we're doing now, we wanted to start relatively small just so we didn't bite off more than we can chew. So we started with just modeling our own little recovery room, which is an area that we knew. We expanded to the physicians. Our current phase we've been working on, thanks to innovation funding from Tehamo for the last several years, We've got input from patients, from families, as well as all of our allied health providers, assessing what their needs are for handover of care. So in terms of, we wanted to have a workable IT solution that we could use earlier on, which we did. But for the next phase, to really research, well, if we're going to build this to expand it beyond just a small physician tool, patients have been at the center of that, and patient and family interviews, patient and family interfacing with the tools that we're proposing has been an integral part of that. So we're still working on that research. We've got all of our data collected, and we're putting it all together at the moment. But they are absolutely at the very center of all of this work.
Are there any health regions that plan to integrate with the Apple app?
That I'm not sure in Canada yet. If you just do a quick Google of the app, there's a whole list of U.S. hospitals that have signed on at this point. Again, it's currently still just in the beta testing, but as far as I know, no Canadian hospitals have signed on yet, but it's still very, very early, and it's still in the development phase and not widely available. So I would suspect that once it rolls out, once they get the kinks out in the U.S., that it would be something more widely available. And just because a hospital isn't using it doesn't mean a patient can't use it to keep all of their information in one place. So sort of a nicer, more concise version of a binder that some people have to carry around. So yeah, it'll be exciting to see what happens with that. There's certainly a number of different healthcare providers that are developing tools like that, but Apple does, because it's so big and so ubiquitous and has so much clout, it'll be really interesting to see what comes of that.
Gina?
Yes.
Yeah, can I pick up on the patient piece? Because I have a patient with me here today, Ms. Connors, who's been listening to our webinar, and she's had her fair share of experiences in the healthcare system. And I wondered if she could just share her perspective about what she has found is working well and maybe what could be improved with the fact that we're having so many people looking after us and how to keep it all sorted and straight. That be okay?
Great.
Okay, go ahead, Ms. Connors.
I think the communication piece is so essential that everyone who's coming into the room says the same thing to the patient, or pretty much the same thing, in the same sort of language. And it has to be in fairly simple language, because usually if you've had surgery and you're on medication, pain medication or blood pressure medication or both, a lot of times you're not really receiving very well. You're laying in the bed and people are going in and out. So things that I find work really very well is when someone comes in, they introduce themselves, they say a few words to you, and then they say, you know what's happened, you're out of surgery, and then they explain what's going on in very plain terms. And also, if they come in and tell you ahead of time, for example, you're laying in the bed, and as I was laying in the bed, and a nurse came in and said, you know, if you have to go to the washroom, whatever you do, don't get up and go to the washroom on your own. Please call us and we will come and get you. Now, I would have never thought of that. I probably would have gotten out of the bed on my own, and as it was, I was very dizzy and groggy and so on. I would not have thought of that unless they told me. So I find things like that very, very helpful. And the simpler the language, really, the better. And sometimes even if they say, did you understand what I said? That's very helpful, too. So I think things have improved over the years. Like I have noticed, I have a bit of a legacy with the hospital system, and I think when people take a few minutes to explain, this is what we're going to do, this is what you're going to experience, but it'll be okay, then that's a huge help rather than just saying, oh, we're going to look after everything, don't worry about it. You know, I think the communication piece has gotten much better in the hospitals with patients, and asking the patient, you know, how do you feel today, or do you have any aches or pains, or they'll ask very specific questions, and I think that has improved a lot, you know. I think one of the things that's very hard in the hospitals now is that people are in a rush all the time, which is understandable because they have a lot of patients, a lot of things to cover. It is very complex because you're using things like working with an MRI or working with a CAT scan or something like that, and you're waiting for that to come. You're waiting to get someone to interpret it, and then the doctor comes and tells you. So sometimes by the time they come, you're really very tired. But I think that has improved a lot. And also, I do notice the idea of the patient-centered care is a lot better than it used to be. A lot of times people would just sort of, I know I had a doctor come one time and sort of open the door and lean in the doorway and say, I'm Dr. So-and-so, how are you? Well, whatever, and then go out the door very, very quickly. Whereas if they come and they approach the bed and they talk directly to you in simple terms, as simple as you can make it, and I do think that's happening more and more. Some are better than others, that's for sure, you know.
Thank you so much. We sure appreciate hearing the patient experience. Jordan, I have another question for you. What tools have worked best for emergency room, and what challenges do you see with compliance for that area?
So again, our emergency department has its own customized tools, so they are using the electronic handover app that you've seen. But sometimes for some patients that are just quickly sort of in, out for a quick, straightforward issue, the time that it would take to enter them into a hospital-type database just doesn't fit the care. So oftentimes they're using what's called a clinical whiteboard, which is sort of a big, looks like a big whiteboard that you might see in a classroom, but it's a digital tool and it sort of helps you or helps them track different patients. I think the key is that each care area, there are going to be some things that are going to be the same as far as what you need to know about patients, and some things that will be very different, information that some care providers might need that others wouldn't have. So yeah, both the clinical whiteboard and the handover tool have been very helpful. The Emerge has also done some work with bedside handovers, so giving handovers instead of handing over at a desk somewhere, they're handing over in front of the patient and their family, which can be incredibly helpful, as you've heard from my colleagues as well. I suppose it's just a thing of not a one-size-fits-all. There'll never be one tool that by itself works perfectly for all care environments in all situations. But I think the important pieces are having a standardized tool so you don't forget the important things, and also having some flexibility in your tool so that depending on whether it's somebody who's in the Emerge for a very short period of time with very straightforward needs or someone who's in with very complex needs, that you can adapt your tool to them.
Thanks. Now, how do you see implementation changing for hospitals without technology and IT support?
Absolutely. I think more and more hospitals are moving to some sort of electronic medical record system. Increasingly, that's being received, not the way I had it with, we were very, very lucky to have an in-house IT development team, and that made things much easier for us. But oftentimes, hospitals do have electronic medical records, have packages that are developed by large companies, so you may or may not have as much opportunity to make those flexible to your needs. But if you don't have an electronic system, there's still lots of tools that can be helpful. I think you would be hard-pressed to find a healthcare provider who doesn't carry a smartphone. Now, that may not be helpful for a specific patient's medical records, but again, if something like the Apple tool is available if patients are signed on, then that's something that patients and healthcare providers can use without needing additional equipment. But also just implementing some of the tools that Dr. McGee was talking about, having a standardized approach to handover, considering implementing things like bedside handover, where again the patient is involved with the handover process and therefore can have the opportunity to ask questions or make corrections. So even if the information technology isn't part of the picture, implementing standardized tools and processes to make handover safer can be done by anybody.
Great, thanks. So then again, what did you do with pushback about confidentiality issues at the bedside?
So we didn't have issues so much about confidentiality at the bedside, although that certainly would be important if you're trying to give bedside handover in a crowded Emerge. If there are other people within earshot, then that could be problematic. That wasn't an issue thanks to our renovated emergency room, so that is definitely a good thing. The confidentiality issue with the electronic tools was more to do with making sure that we were completely HIPAA compliant, that we were protecting all patient information, So that's just it's just an extra layer that you have to be very careful of when you're designing and implementing a tool. So where is the data stored? Who has access to that data? And making sure that that your electronic tool adheres to all of the same principles of patient data confidentiality, as you don't let just anybody walk around with a patient chart, and you don't let just anybody have access to a patient's records. Done well, though, the electronic tool gives you an extra safety layer, because unlike a paper chart, the electronic tool can log who accessed that chart, who looked at it for how long, what information did they look at, and that's not something that you get with paper. So if done well, it gives you an extra layer of confidentiality, but certainly there's data breaches and all that sort of thing in the news on a pretty regular basis. So the bar is very high for how airtight your security has to be on patient records.
Okay, thank you. There are no further questions in the chat box, so we want to respectfully thank our two fabulous speakers for sharing their time and expertise today, and thank all of you for taking the time to attend. We know how busy your day is and appreciate you taking the time to attend the great webinar series. Please visit our website for a taped version of the presentation and to sign up for the next webinar in March. If you want to continue this conversation or you had a question that wasn't addressed, feel free to send us an email. You should all receive Gina Peck's follow-up thank you email in your inbox shortly, and you can respond to that. Have a wonderful day, everyone.